So just to summarize, I think that we at least believe for this population it is appropriate based on many factors. It is clearly a novel option. If you look at the literature on cocaine abuse, it falls into two categories: the psychosocial interventions that actually focus on cognitive behavior therapy, contingency management, and some of the medication-based interventions, although no drug actually has been shown to be strongly efficacious for that population yet. And there has been some interest recently in the cocaine vaccine, and you must have seen those results. The efficacy of that intervention, even a cocaine vaccine, is modest because not everybody actually benefits. They don't develop the antibodies enough to be able to work. So therefore, while it is efficacious for a small group of patients, it is also not the solution. So this is indeed a novel treatment. If we can engage patients in this and they have been trained, then you may not need ongoing supervision. They could potentially be monitored, especially now with electronic monitoring approaches available. As you know, with a lot of social media PDAs, you can actually get much better contact with patients. So you may not need supervision and still get a sense of whether or not somebody is exercising. It clearly will meet multiple needs. Behavioral therapies are critical. And exercise is rewarding non-drug using activity as opposed to drug using activity, and still has a substitutive effect. That is, it actually allows the patient to engage in repetitive positive behavior on an ongoing basis, which is actually one of the patient's problems, is they get into repetitive behavior, but the repetitive behavior they get into is drug-seeking behavior. And then coexisting disorders, comorbidity with anxiety and depression, post-traumatic stress disorder for these populations is actually very high, and therefore it may have additional benefits. And maintenance can and may reduce relapse in the long run. So that's the bottom line rationale for us in terms of why we did this. And yet, like I said earlier, we're not aware of large-scale publications or studies that have shown results yet on whether or not it is efficacious. So our interest at that, as a result, was at what point should we introduce it? And as I mentioned more than once, we could have started using it as a monotherapy and studied its efficacy. We decided to use it as an augmentation to standard, usual care, intensive treatment that patients are engaged in the treatment settings we are going in. And the target outcomes are direct in terms of withdrawal symptoms, craving, as well as indirect in terms of cognitive function comorbidities.